Okay,
Yes,
so
Dr.
one question for Dr. Sarah, saying, why did you start with CT in this 7 years old child when you could have given the diagnosis by ultrasound, the case of the ascariasis?
Sure. So actually, the patient had a first ultrasound looking particularly for the region of appendix, which came back negative. And thus was the correct diagnosis. The patient had no appendicitis proven by the CT that followed. And we suggested that the CT, the possibility of ascariasis or lipoma and the region of the terminal ileum with complicated by subclinical intussusception. Actually, the patient went back to the surgeons who were not happy or not really sure about the diagnosis and came back for a second consultation with our doctors, who suggested to repeat the ultrasound, focusing at that time for the region of the terminal ileum. The ultrasound was done by a more experienced radiologist, Dr. Dawood Al-Shimali, who had a great interest and a good talent performing bowel ultrasound, focusing on that region. Only at that time he was able to see the Ascaris worm, the live worm moving within the bowel, and send the patient back to the surgeon, who were this time happy with our diagnosis, and the patient underwent surgical procedure confirming the presence of ascariasis and intussusception. So you are completely right. Always start with ultrasound in pediatric population. Sometimes it's challenging, or the ultrasound is not 100% correct, but that was not the case in our patient. The ultrasound confirmed the absence of appendicitis. Patient was still symptomatic. We did the CT later on, looking for another possible diagnosis, and which came back positive, as we mentioned, with subclinical intussusception and ascariasis. Hopefully I answered the question there, Dr. Wael.
Thank you, Dr. Sarah.
Sure.
The second question goes to Dr. Reem. What's the role of the biopsy in suspected thoracic infection in the lung and in the chest wall lesions, for example?
If you are asking about the indication and the role of biopsy in infection in the chest, there is no international guideline to say yes or no that we need to biopsy these lesions, honestly. But if the clinical manifestation and imaging finding didn't give an answer to the referring physician, what is the diagnosis and how they can treat the patient, then a tissue sample is indicated to reach a professional diagnosis. For example, the case I present, usually when we are suspecting abscess, we don't rush into a biopsy, we aspirate. And if there is a collection or pus or a fluid coming out of whatever lung mass, cavity, or chest wall mass, we will send for culture sensitivity, acid-fast bacilli, and fungal screening. But if we are unable to aspirate and all we have is a solid tissue with overlap differential diagnosis, malignant versus benign, we need to core it and we need to get a tissue sample. Moreover, even in the malignant cases, review literature, they mentioned that in the presence of chemotherapy, immunocompromised patients, even in the oncology patient, they may develop fungal infection, organizing pneumonia. These findings are confusing to physician. So is this a new malignancy, or this is a non-malignant lesion? This is infectious, or this is inflammatory lesion? Patients need chemoradio or antibiotic or steroid therapy. In this case scenario, then yes, the biopsy is indicated. I hope I answered the question.
Thank you, doctor.
And it's clear. You're welcome.
So another question for Dr. Fatma. Dr. Fatma, when you are doing CT or MRI for the brain, does timing after IV contrast injection make a difference?
So timing after IV injection does not necessarily make a difference. We don't do CT for meningitis, enhanced CT for meningitis. Usually these patients come to us from peripheral hospitals. Usually our studies are with enhanced MRI, and it is known that as per protocol, the SPGR, sometimes it's deceiving whether what you're seeing is just vascular enhancement within the subarachnoid spaces that are showing slow blood flow, or this is actual leptomeningeal enhancement. But it's just the way that with the practice, with experience, you will be able to separate the two. It is known that leptomeningeal enhancement shows continuous enhancement along the cortical surfaces within the subarachnoid spaces, unlike the vascular enhancement, which is interrupted. However, enhanced flare sequences are the most sensitive conventional sequences that we can use in the daily practice to look for leptomeningeal disease in general, and in these cases for leptomeningeal enhancement. The downside is sometimes the artifacts you get in patients under anesthesia from oxygen, but with the enhancement, this should not make a big difference. Usually we do the studies using hand injection, so the imaging does not usually start until 30 minutes after the injection, 30 seconds after the injection. This is good enough time for if there is inflammatory changes within the meninges to for the meninges to take the contrast, and we will be able to visualize any abnormalities. Thank you.
Thank you, Dr. Fatma. Now I will handle the mic to Dr. Mashal again.
So by this, we reach the end of our meeting for today. I hope that you find it interesting, and I would like to thank again my respective speakers for participating in this live webinar. Our audiences, and please, and also of course, sorry, my colleague in the organizing committee, Dr. Reem and Dr. Wael, and I hope until we meet again, please just this is a reminder to complete the evaluation forms so that you can get your certificate, the CME, in the coming few days. So please stay safe, and thank you and goodbye.
Good night.